Welcome everyone. This is the first lecture of the Crystalline Lens among the Special Senses module, and I'm Karim Gawala, Assistant Professor of Ophthalmology. I'm really honored to be with you today. Let's start with the anatomy. The lens is a transparent biconvex structure with anterior and posterior surface separated by the equator. The center of the anterior capsule is called the anterior pole, and the center of the posterior capsule is called the posterior pole, and the line joining them is called the lens axis. The equator is encircled by the ciliary processes of the ciliary body and lies half millimeter from them. The lens is kept in position by the suspensory ligaments. Looking at the embryology, you can see the neural tube. Just to summarize the embryology, the surface ectoderm gives the epithelium of the cornea, conjunctiva, and the lens, while the neural ectoderm gives the optic cup, which is formed of two layers, outer layer and inner layer, and it gives the retina and the pars iridica retina and pars ciliaris retinae, and the mesoderm gives all the other structures in the eye, including the capsule of the lens. So the lens is formed from the surface ectoderm, and the capsule of the lens is formed from the mesoderm. That's why we can separate between the lens and the capsule during the surgery. Remember this point. We have two other things that you have to remember from the embryology. The first thing is that we have a lens stalk that must disappear before birth, and we have a hyaloid artery that must disappear at birth. If any of these remains after birth, we will get something about, from the congenital anomalies that we will discuss later. Looking at the lens, you will find that there is anterior epithelium just behind the anterior capsule, while the posterior capsule doesn't have any epithelium. You will find that the embryonic nucleus is just in the middle, followed by the fetal nucleus, then the infantile nucleus, and then the outer adult nucleus, and they are separated from the capsule by the cortex. Looking at the other the second picture, you can see that this is the equator, and there is some equatorial cells responsible for the production of new lens fibers. The lens sclerosis usually happens at the age of 30 as the lens doesn't increase in size, so the central fibers are compressed and dehydrated, which leads to formation of the central soluble lens protein into hard insoluble lens protein. This is considered physiologically normal process. It doesn't interfere with visual acuity by any means, but it affects the accommodation. When examining the patient, you will find that the central nucleus is grayish in color, but the lens is clear and the red reflex is normal. As the lens is avascular, so the nutrients of the lens comes from the nutrients dissolved in the aqueous humor. The lens is one of the refractive media of the eye, although the cornea is the main refractive media of the eye. The diopteric part of the eye, of the lens inside the eye is 16 to 18 diopters, while outside the eye it's 70 diopters, as it tends to coil to increase the curvature, and due to difference of refractive index of the air in comparison to the aqueous and the vitreous. It is responsible for the accommodation. It has a retinal protection role, as it absorbs the hazardous ultraviolet rays, protecting the retina from the effect of the ultraviolet, and it neutralizes the spherical and chromatic aberration of the cornea, leading to improvement and better visual quality. Congenital anomalies of the eye includes the congenital aphakia, which is a very rare condition in which the lens is absent. The second thing is the ectopia lentis, in which the lens is subluxated or dislocated, as in Marfan syndrome and homocystinuria. The third thing is the lenticonus, which is abnormal curvature of the lens, mainly in the posterior, but it may be in the anterior surface. Coloboma of the lens, which means a notch-shaped defect of the margin, and this is usually the inferior part of the lens. Microspherophakia means small spherical lens, and this is usually bilateral. And the most common congenital anomaly is the congenital cataract. The congenital cataract might be congenital or infantile, and we will discuss it later. So as you can see, the first two images are ectopia lentis. Just to show you that ectopia lentis could be with a clear lens or with a cataractous lens. The third picture, you can see that we have an abnormal curvature of the anterior capsule, and this is called the lenticonus. The fourth and fifth pictures are the coloboma of the lens, and as you can see, it is bilateral, and you can see that it's not dislocated, and you can compare it with the upper picture of the ectopia lentis just to notice the difference. In the first two pictures, you can see that the lens is complete, while in the coloboma of the lens, you can see that there is a defect, and it is usually bilateral, and it is usually in the inferior part. Next picture is the congenital cataract. As we said, this is the commonest type of congenital anomaly of the lens, and this will be discussed later. And last picture is a microspherophakia, and this is usually bilateral, small spherical lens. So the cataract, which is the opacity of the lens, the word cataract refers to water fail. يعني لما ظهر الكاتراكت, it was named cataract due to the water fail, due to an old theory claiming that the opacity inside the eye is caused from some water that fall from the brain inside the eye, which is not true by any means. So the etiology, the classification of cataract could be etiological classification or surgical classification. The etiological classifications include congenital or developmental cataract or acquired cataract. The acquired cataract includes senile cataract, which is age-related cataract, or traumatic or complicated or even toxic cataract. The surgical classification is either soft or hard cataract, and this is usually related to the age. So if this is before the age of 30, which means before the nuclear sclerosis, it will be a soft cataract, and if it happens after the age of 30, usually it is a hard cataract. So now we will start with the congenital cataract. The congenital cataract is present at birth, while the infantile cataract develops at the first year of life. It might be unilateral or bilateral, and amazingly, it might be visually insignificant. So not all the cataract are affecting the vision. The causes of congenital cataract are multiple. The first one is the gestational disturbance, which means that intrauterine infection, for example, especially the rubella, mumps, herpes, and toxoplasmosis, which are the most common organisms. The maternal drug intake, especially for corticosteroid or sulfonamide. Irradiation during the first trimester of pregnancy, and nutritional, especially if there is calcium or vitamin D deficiency. For the metabolic disorder, if the patient or the child or the infant has diabetes mellitus or hypoglycemia or galactosemia or even hypoparathyroidism. And trauma, which is either mechanical or electric. The mechanical might be concussion or blunt trauma or penetrating trauma. The electric shock also might lead to cataract. For the congenital anomaly, for the ocular anomaly, it includes many things such as aniridia, ectopia lentis, which will be discussed later, persistent hyperplastic primary vitreous, or maybe congenital anomalies of the lens. There's many classifications of the congenital cataract, but the most popular is the morphological classification. The first type is the polar cataract, in which there is lenticular opacities involve the lens capsule and the subcapsular cortex. It might be anterior polar cataract due to the delay of disappearance of the lens stock, or posterior polar cataract due to the presence of the hyaloid artery or the delay of its disappearance. We have to differentiate between the congenital anterior polar cataract and the acquired anterior polar cataract. The acquired anterior polar cataract is usually caused by blunt penetrating trauma leading to a scar in the cornea and anterior polar cataract. So it is usually unilateral and it has opacity in the cornea, while the congenital anterior polar cataract is bilateral with clear cornea in both eyes. The posterior polar cataract has a greater effect on the visual acuity due to the larger size and because it's closer to the nodal point of the eye. Lamellar or zonular congenital cataract is the most common type of congenital cataract, and it's usually bilateral. Bisexual, there is a layer of opacification involving the fetal nucleus surrounded by a clearer center. And as you can see in the picture, there is a front view of a disc-shaped configuration. There is arcuate opacities often straddle the equator of the lamellar cataract, and these opacities are called riders. Causes of lamellar or zonular cataract may include transient toxic influence during embryogenesis. Also, calcium and vitamin C deficiency during pregnancy might play a role. The complete congenital cataract. The coronary cataract is not a congenital cataract, it's a developmental cataract, and usually manifests at puberty at the age of 13 to 15. The opacities are club-shaped near the periphery of the lens with their bored ends toward the center. The central region and extreme periphery of the lens remain clear, and it's formed due to the new formed lens fibers at the equator. This is another type of congenital cataract, which is a blue dot cataract. This is common in Mongolian. It consists of multiple small bluish dots scattered all over the lens, and it has no visual affection. So this type of cataract doesn't need any intervention. Just this is accidental discovery of cataract, and it doesn't affect the vision, and it doesn't need any intervention. The nuclear cataract might be caused by error of metabolism or toxin from the mother, like rubella or measles, especially during the first trimester, and sometimes due to vitamin C, vitamin D, and calcium deficiency. This is usually bilateral, and it may involve the embryonic nucleus alone or both the embryonic and the fetal nuclei. The sutural or stellate congenital cataract is another type of cataract that doesn't require any intervention. It doesn't affect the vision, and it affects the fetal nucleus. If the opacity is in the anterior part of the fetal nucleus, the opacity will appear as a Y-shaped opacity, and if it happens at the posterior part of the fetal nucleus, it will appear as an inverted Y-shape or the Mercedes sign. And once again, it doesn't require any intervention, and it doesn't affect the vision. Membranous type of congenital cataract, in which the lens protein are resorbed and only the anterior and posterior lens capsule remain and fuse into a dense white membrane. So by a slit lamp, you will find that this opacity is only a sheet of anterior and posterior capsule fused together, and the patient doesn't have any lens. So to summarize, remember the difference between the anterior and posterior polar cataract is that the anterior polar cataract is caused by the delay of disappearance of lens stock, and the posterior polar cataract is caused by persistence or delay of disappearance of the hyaloid artery. And remember how to differentiate between the congenital anterior polar cataract and the acquired anterior polar cataract. Remember that the lamellar or zonular cataract is the most common type, and it's usually bilateral. Remember that the complete type of cataract may start as subtotal cataract, and it has a profound visual impairment. Remember that the coronary cataract is not congenital, it's a developmental. It's extremely important to remember this point. Remember that the blue dot cataract and the sutural or stellate cataract does not affect the vision and does not require any intervention. Remember that the patient with membranous cataract doesn't have a lens. It has been absorbed. And remember that the nuclear cataract may be caused due to the error of metabolism or toxins from the mother, or some deficiencies like vitamin D or calcium deficiency. And we have now another type of cataract, which is the rubella cataract. This is another type of congenital cataract called rubella cataract. It's caused by maternal infection with rubella virus, and this can cause fetal damage, especially if infection occurs in first trimester, leading to cardiac defect, deafness, mental retardation, and ocular manifestation. This type of cataract is characterized by pearly white nuclear opacification and can progress to complete cataract. So the complaint or the symptoms are usually from the parents. The parents will complain from defective vision of the child, or from leukocoria, which is known as white reflex, which is known as leukocoria. And this happens if the cataract is dense and involving the central part of the lens, and it's easily discovered by the photographs. The third thing is the squint, which is usually accompanied by amblyopia, especially in unilateral cases, and nystagmus, which happens in bilateral dense cataract. So for proper visualization of the lens and for the red reflex and fundus examination, we have to apply mydriatic eye drops to examine the fundus and the patient. Morphology of the cataract varies according to the type, which was discussed. And in older patients, slit lamp examination is very helpful. The management of congenital cataract depends on three things: the eye, either it's a unilateral or bilateral disease, as prognosis is guarded in unilateral dense cataract; density, as in dense cataract, fundus examination will be extremely difficult with both direct and indirect ophthalmoscopy; morphology of the cataract, which is best assessed by slit lamp biomicroscopy, which might be very difficult, especially in young patients. We have to search for associated pathology that might affect the anterior and posterior segments. And extremely important to check for the visual function test to make sure there is a central fixation, either it's present or absent, to make sure there is no nystagmus and strabismus. The second thing is the patient. The patient should be examined by a pediatrician with special reference to associated systemic diseases. It's extremely important to exclude the rubella, metabolic, and biochemical defects. And mentality of the patient should be assessed too. The third thing is the parents. The parents should be examined to exclude hereditary cataract and maternal intrauterine infection, or even ingestion of drugs during the pregnancy. And it's extremely important to do the motivation of the parents to participate in the frequently demanding and complicated post-operative care of their children. The treatment of congenital cataract might be non-surgical treatment or surgical treatment. In some patients, we don't need treatment, like in blue dot cataract and sutural cataract. While in non-dense cataract, optical treatment might be a very good option if the glasses can improve the vision to 6/18 or more, so we don't need to do surgery. Why? Because if the eye can see 6/18 or more with glasses, this is much better than a 6/6 eye without accommodation. So to preserve the accommodation, we can go for glasses. For the surgical treatment, if this is a unilateral dense cataract, so this surgery is considered as an emergency and it should be done upon the first few days of life. If it's a bilateral dense cataract, so it should be done in the first few weeks of life before the development of the fixation reflex, which usually happens at the 3rd month. So we should do the surgery before this age. If it's a bilateral faint cataract, and if the vision of the patient is less than 6/18 with optical correction, we can consider the surgery. Surgical techniques includes irrigation aspiration, which is a safe, effective procedure for the treatment of soft cataract. Remember to try to do the posterior capsulotomy and anterior vitrectomy just to minimize the post-operative capsular opacification and to decrease the post-operative reaction. And the best scenario ever is to implant an intraocular lens during the surgery. But you can postpone this step to another session. The second thing is to do a lensectomy. The lensectomy is performed through the pars plicata or pars plana by removing the whole lens, including the anterior and posterior capsule, and doing an anterior vitrectomy. Correction of aphakia. Aphakia means no lens, so the patient with no lens, as if we did an irrigation aspiration without implanting an IOL, can be corrected with contact lenses or glasses. And sometimes we need 2 pairs of glasses, one for far and one for near, and usually we do bifocal glasses instead of doing 2 glasses. And IOL implantation if there is a support to implant an IOL. Complications of surgery for children is exactly the same as in adult, with greater reaction post-operative. Glaucoma and retinal detachment and opacification of retained posterior capsule are more common late complications of congenital cataract. The complications of surgery will be discussed later in the other lecture. For the prognosis, visually significant cataract always result in deprivation of amblyopia if left untreated. Once nystagmus has developed, it persists even if the cataract are subsequently removed. A timely operation will, with clearing of the visual axis and promote refractive correction and aggressive amblyopia therapy by occlusion, can yield good visual function even in unilateral dense cataract. Now we will start with the senile cataract. Senile cataract is opacification of the lens affecting the old people, and it's not due to local or general disease. So it is considered as the process of degeneration of the lens fibers with hydration and opacification. The disease is usually bilateral, but one eye is usually affected more than the other one. The disease itself is multifactorial and it's not completely understood. The types are divided into cortical and nuclear. The cortical cataract is either cuneiform, which means مسمارية الشكل, and this is subdivided into precataractus, incipient, premature, mature, and hypermature, and every one of these will be discussed later, and cupuliform cataract, which is related to the posterior subcapsular cataract. In the cuneiform cortical cataract, the effect of the opacity on the visual acuity varies greatly depending on the location of the opacification in relation to the visual axis. It has several stages. The first one is known as the precataractus changes, in which by slit lamp examination you can see lamellar separation, which is also known as cleft, as well as water vacuoles. The second stage is the incipient cataract, in which you can see a white wedge shaped opacity in the periphery, and you can detect that the center of the lens remains clear, and amazingly, the central vision is minimally or even not affected. The third stage is the immature stage, immature senile cataract, in which the cortex all become opacified except a zone of a superficial cortex under the lens capsule. The iris shadow is detected by examination, and the vision in this stage amazingly may be as high as 6/18 or even 6/12. The next stage is the mature stage, in which the entire cortex from the capsule to the nucleus becomes opaque and white, and visual acuity is deteriorated to hand movement, and the red reflex is not seen. Last stage is the hypermature stage, which is subdivided into two subtypes. The first one is the common type, or the usual one, which is known as the shrunken type, in which there is leakage of degenerated cortical material through the lens capsule, leaving the capsule wrinkled and shrunken. The second type is the Morgagnian cataract. In this type, there is liquefaction of the cortex, and the nucleus is moving freely inside the cortex, and as you can see in the picture, you can identify the nucleus, the brown one, sunken inside the liquefied cortex. Another rare type of cataract is known as the Christmas tree cataract, which is a polychromatic needle-like opacity. It may appear alone or with other type of opacities as in the second picture. The other thing is the intumescent cortical cataract, which is a phase that may or may not happen during the maturity of cataract. Here, the lens continues to take up water, it swells, and may induce thecomorphic glaucoma. The other type of cortical cataract is the cupuliform cortical cataract. In this type, the opacity is posterior subcapsular. There is poor visual acuity in bright light, and the near vision tends to decrease more than the far vision. The nuclear cataract results from excessive amount of nuclear sclerosis and yellowing, which causes central opacity. The progress is slow, and it interferes more with distance more than the near vision. In early stages, it causes a myopic shift, and by time the lens nucleus may acquire a brown color and is called brunescent nuclear cataract. And by time, if the density increase, the color becomes black, and it is then called cataracta nigra. The main complaint of the cortical cataract is a gradual, painless diminution of vision. The patient with cortical cataract complains from glare from intense light source, while the patient with nuclear cataract complains of interference more with the far vision, while the patient with posterior subcapsular complains more from the near vision. Other symptoms are possible, like the uniocular diplopia or fixed black spot, or even shift to myopia. The signs of senile cataract can be examined clearly and easily with a slit lamp after dilatation of the pupil, just to check the periphery of the lens, anterior and posterior capsule, and to check for the vitreous and the retina. The main complications of cataract are either lens-induced glaucoma or lens-induced uveitis, or spontaneous subluxation and dislocation of the lens. For the glaucoma, it is subdivided into phacolytic and phacomorphic glaucoma. The phacolytic glaucoma is a complication of mature or hypermature cataract, in which the lens proteins leak through the lens capsule, become engulfed by the macrophages, and clog the trabecular meshwork, leading to acute rise of tension. And this is the first picture. For the phacomorphic glaucoma, it's more mechanical, as it is a complication of intumescent cataract. The lens increases in size, and this leads to pupillary block, and actually causing forward displacement of the iris, including secondary angle closure glaucoma. And you can see that the cornea is not that clear in the second picture, and you can see that the AC is shallow and the angle is narrow. For the lens-induced uveitis, it's a phacoantigenic uveitis, and is an immune-mediated glaucomatous inflammation initiated by the lens protein released through a rupture lens capsule. Either it's a traumatic or post-surgery. In all these complications, lens extraction is indicated after medical control of tension. And for the spontaneous subluxation and dislocation of the lens, it may occur in hypermature stage. So this is the first lecture. Wait for the second lecture. It will be available very soon. Please don't hesitate to send me an email whenever you need anything. Thank you.